representative from the department. And we have a new representative from the Department of Agriculture. That's Jill Weishart. Jill, if you are on, do you want to, oh, there we go. Say just good morning to the group. You would be on mute, which is like totally what happens Monday morning. Well, your flowers look good, so we'll let the pollinator. I will put you on the welcome, Jill. If you get that figured out, you're more than welcome to pop in and say good morning to the group. This morning we have Senator Solomon here, I believe. Is Senator Solomon with us? He is going to just sort of give a few comments this morning. Then we're going to follow that up with a patient safety panel discussion, which I'm really excited about our speakers. And when we get to that, I'll introduce them a little bit more formally. Then we're going to hear from Duncan and the results of the interviews that he did with most of you, sort of 4 themes. That should get us through the meeting. I do want to let folks know we will have another meeting like before the end of the year from in which we'll hear more from the Department of Health about kind of what their abilities are now to enact some of what's in the legislation proviso, as well as what would need to happen in the future as things go forward. Okay. All right. So again, good morning. I don't know that we necessarily need to take the time to have the committee introduce themselves to each other. I think most of us, with the exception again of Dr. Silvas and Jill, have joined us before. We do have our next meeting scheduled already, and that is December 2nd from 9 to 10:30 a.m. And hopefully the invitations have gone out. So again, want to say good morning. This is our, I believe, 4th meeting. We are working through the report that's due to the legislature in a draft format. We will have that ready to go for December. And we do anticipate that this committee will meet again at least once or twice next year, just to continue to finalize up anything. But any legislation that will happen will be directed by the legislature this year. And with that, I want to see Senator Solomon on the phone. Let me see if he was able to join us. Kevin, do you know if the senator is able to join us this morning?
I don't know.
Okay. Well, we're running a little bit ahead of time. Well, let's do this just because we're a little bit ahead of time and I do want to give them the opportunity. I'm just going to go through the committee list, and if folks could just say good morning, that would be great. Dr. Sunil Agarwal. I apologize.
Oh, hi there. Hi. Sorry, I'm driving. I'll
No worries.
be in a desk in a second. Good morning. Hello.
Good morning. Ada Danella.
Good morning.
Good morning. Jermaine Danabel. Apologies.
Beautifully done. Good morning. You pronounced it perfectly. Thank you.
Excellent. Lacey Fehrenbach.
Good morning, everyone. Glad to be here with you.
Kate Foster.
Hello.
Oh, there you are. Hello. Good morning. Jeremy Grisham has taken a new employment, so he will not be joining us for any further meetings at this point in time. Dr. Jay Kennedy.
Oops. Good morning.
Good morning.
Nice to see you.
Emma Knighton.
Hello. Good morning, everyone.
Good morning. Seth Meyer. I saw Seth. There he is.
Yeah, good morning, everybody.
Dr. Alvina Maris, apologies. And maybe Dr. Maris is not able to join this morning. Okay, Kelly McLean, who is now Jill Weisart, welcome. Jim Morgan, is Jim with us this morning?
Yes, good morning.
There you are, excellent. Dr. John Roll, I did see Dr. Roll here. There you are.
Yep. Hello, everyone.
Good morning. All right, Dr. Tony Rousmanier.
Good morning, everyone.
Good morning. Dr. Caitlin Ryan. All right, maybe not. Dr. Nathan Sackett.
Morning, everyone.
Good morning. Dr. Tana Silvas, I don't know if she was able to join us or not. Hopefully she'll be able to listen in at some point. Paul Stamets.
Hi there, everybody. Good morning to you.
Good morning. Cody Zaleski, I'm sorry.
Hello here. Yeah, no, that's fine.
Hi, Cody. All right. And I think I captured everyone on the committee. All right. I don't see Senator Solomon at this point. Just scanning the. All right. Well, if he is able to join us, we can certainly have him join after this discussion. So I want to move next to just introducing our panel. Again, I'm really excited to hear from them. I believe, Cody, did folks get their bios in the invite?
Yes, it was attached to the meeting invite.
Excellent. So you can certainly read that. I am looking forward to the discussion. So I will just say that we have Dr. Alex Cardenas, Dr. Brian Anderson, Dr. Henry Harbin, and Bob Jesse. And what I thought we could do is I have some questions prepared. We could ask the panel and then have some time for conversation at the end. And of course, I have, let's see, here we go. Here are the questions. Sorry about that. All righty. So do you all want to, maybe what we could do first is just go through and have you do a brief introduction for yourself so folks have some grounding, and then we can get started with the questions and again have hopefully ample time for the group. So I'm going to start with Dr. Cardenas. If you would say an introduction, that'd be great.
Yeah. Good morning, everyone. My name is Alex. I'm a community and safety net psychiatrist by training. I'm also the co-founder and executive director of the American Psychedelic Practitioners Association. And I sit on several committees around safety in Oregon, so hopefully be helpful here.
Welcome. Dr. Anderson.
Good morning. My name is Brian Anderson. I live in San Francisco. I'm on faculty at UCSF. My clinical work is in the psychiatric emergency services of our county hospital. And my research background includes clinical trials, but for a long time before that, I also did drug ethnography. And so I've done participant observation with psychedelic using communities going back many years. And I guess one of my probably main contributions to the conversation today would be around engaging with psychedelic churches or religious communities that have used ayahuasca and other compounds for generations.
Thank you. Dr. Harbin.
Okay, thank you. Appreciate the invite to be here today. I'm a psychiatrist by background. I've been in this field probably too long, but 40 plus years. So I've played a role kind of in the public health side for 10 years, in academia for a couple of years, and then with the managed care industry for 15 years. But most of my work in the last 10 years has been trying to help drive policy and practice reforms in behavioral health nationally. I'm really here because I'm on the board of an advisor to Brain Futures, which is a nonprofit that has been trying to help in the psychedelic field. First thing we did was issue 3 issue briefs papers, one on a review of the evidence for the last since 1950. The second one was on what steps need to be done to get full commercialization and implementation of these compounds safely. And thirdly, we just released a paper on interviewing 20 plus experts in psychotherapy or psych therapy with these compounds, and basically kind of trying to highlight what some of the really experienced clinicians and guides have and offer. So today I really would, so I'll kind of be speaking from that role in today. I did my claim to fame on the psychedelic field was I was one of the last subjects in FDA-approved trials back in 1973 when I was a resident in psychiatry, and the Maryland Psychiatric Research Center was still active, and they were doing, FDA trials, and all of our residency class were allowed to be subjects, which we volunteered for. So, thanks. Look forward to the discussion.
Thank you. And Bob Jesse.
Good morning, everyone. My name is Bob Jesse. I live near San Francisco, and I've been active in the psychedelics field for about 3 decades now. One key part of that was helping to form the psilocybin research team at Johns Hopkins, and I'm still affiliated with that team. I've helped to conduct and publish a number of its studies. I'm now affiliated with the newly minted Berkeley Center for the Science of Psychedelics, also with USONA Institute in Madison, Wisconsin, and several other groups in an advisory role. And I'm very excited to see how state-level initiatives will unfold.
Great, thank you and welcome. One of the questions in the chat I got is what is the purpose of this meeting? I think that the purpose of this meeting is severalfold, or the hoping of this panel discussion. In looking at the feedback to date and participating in the meeting so far, this group has sort of decided that the direction that it is most comfortable taking or wants to move forward is that from a model where it is a wellness model, that it is not a clinical model, that it is a wellness model. We've had discussions about training. We've had discussions about how long. We'll hear some feedback from your thoughts about that when Duncan reviews the survey results. And we think that it, is important to have sort of a 360-degree view of psilocybin psychedelics. And so we want to make sure that we paint an accurate picture of both the benefits as well as the potential concerns by having people whose careers it is studying these are involved in this. So this is really to make sure that the group has all the information as we go forward and continue to work on the recommendations. The plan is a draft plan that we're submitting in December. I do not expect it to be completely finalized in every way. So want to really just provide this group as much information as possible, given that it's recommending sort of future directions for legislation in this state. So that's sort of what we're hoping for today, bringing in, again, some of the scientists who've been directing their careers to this and just broadening the perspective. So want to first start with going through what safety-related recommendations would you have for the state of Washington as it looks to implement an Oregon-like psilocybin program? And when I say Oregon-like, I know we're not talking exactly, but just in the spirit of what Oregon has done, what sort of safety-related recommendations might you have as Washington pursues a similar path, although not exactly? So I want to go ahead and start with Alex. Is it okay if I call you Alex? Do you mind?
Sure. Yeah, I think especially learning from the Oregon model, I think there's 3 phases of kind of safety concerns. One is screening, and who can screen and what are their competencies, especially if you're leaning more strongly to the wellness model. It's a question of what's happening in Oregon is this question of liability. And so I'll just bring to people's attention that even going to the gym has screening criteria that allow even like someone in the gym to refer someone to a doctor for a workup. And that's something that even Oregon is struggling with in their wellness model legalization process, is can they even recommend someone be screened by a doctor prior to getting these services? And so questions around medical history, psychiatric history, and safety history are challenging because who's qualified to ask those questions and who knows what to do with those answers? So I think that's a big challenge in this model where there's no like, parallel medical model to rely on. And so the way Oregon is currently thinking about it is making it really either optional or just like you cannot force the questions, people can offer them voluntarily, and that kind of moves the liability towards the consumer. And the kind of corollary to that, making it very clear that people with a behavioral health background are not acting in that capacity, which then ties their hands to even asking those questions. And so I think that's a really big challenge to figure out is the screening process, who can screen. Related to that, just speaking as a doctor, it's really hard for someone to come into my office for a medical or psychiatric screening for a psilocybin service for me to sign off and take on the liability that this person is medical stability is a little easier, but psychiatric stability for a service I'm not attached to is very challenging. So it's a very challenging question around screening. The other issue that is also something I think Oregon is facing is that the medical model does a couple of things. One, it provides a level of care for people who need that skill set. It also provides for some level of equitable access through insurance coverage, but in particular, it provides a safety net for the rare but expected number of people that will need services beyond the 8-hour model in an outpatient clinic. And so I can tell you that being in a psychiatric ER is the wrong place to be if you're having a persistent psychedelic experience. And so setting up some level of service centers that can provide extended care and specialty care for those situations would be important things to consider. And this, well, I think we'll get into this medical versus wellness question, but I do think that a multiple tier certification would solve a lot of these issues because it would allow people with a higher tier or an alternative tier background to act in those capacities formally when that addresses screening. And that also provides different levels of care for people. Instead of being turned away, they're turned towards a system that could help them in a certain way.
Great, thank you. Brian.
I'm speaking as a psychiatrist and someone like Alex who works in the psychiatric ED, but I don't want my comments to be seen as overly medicalizing or sort of solely focused on what's going to happen in the medical setting. I just want to start by saying I think it's really powerful for a certain geographic area and community to choose to pursue a wellness model, but to do that rigorously. And I think one of the big safety things will certainly start with public education and how whatever legislation is passed is talked about in the community. So from the perspective of some of the confusion I've seen about how psilocybin access in a decriminalized or regulated model for wellness or adult use is predicated on the fact that there is some preliminary data on how this is good for depression or anxiety in clinical populations in highly restricted clinical research settings is something we need to address. I think we should educate the community about how the safety data from just maybe a few dozen to a few hundred participants who've received this for clinical reasons is not very generalizable. And so I think from a safety perspective, we have to have a good sense of what can we actually say in our communities based off of what's been published in the few papers that are out there so far. So certainly starting from that point, also going to then educating providers who are like Alex or others on this call who will be called when people are having a hard time post psychedelics. I think this is a big safety problem that I'm seeing is that most of my colleagues in allopathic medical care are not comfortable. They don't know how to interpret these experiences. They don't know how to meet people where they're at and even think about that initial referring response. Do you just give them benzos? Should you give them Seroquel and bring them down? Do you need to get them to a talk therapist or a guide or a facilitator or a coach who can help them work through what they're doing versus trying to just stop it in its process? And this is the sort of level of experience I really don't see in the clinical allopathic world in the United States these days. Again, a lot of my experience is drawn from working with churches, and these are communities with, again, generations of often giving high doses of psychedelic plants or fungi to people in a frequent basis, sometimes monthly, if not more frequently than that. And we do see adverse events happen, but having a community wrapped around that, where you, the providers, your family, your neighbors have seen this before, they can interpret and figure out which ones are the ones that need escalation of care and what are the events they're going to resolve with a little bit of support and time. That's a sort of a cultural level of preparedness for safety and working through challenging times that we have to build up to slowly. And so thinking about systems of getting our providers ready to reach out to experts and have them weigh in on, is this one of those cases that you think will need months or just days, is a key part of getting people ready to deal with things that come up that are uncomfortable or challenging.
Great. Thank you. Henry.
Okay, take myself off mute. Thank you. Well, I like some of what Alex said about what are safety concerns. Screening, certainly to me, the screening process and who does it, and the facilitation process and who does it are core to safety issues, whether you're doing a wellness model or a medical model, both. So I did a pretty detailed analysis of the last draft of the Oregon regulations on this, and I particularly was looking at those issues. I've sent a copy of that to Mike and Charissa, so I'd be happy to send a draft of that to anybody that wants that. So and I know you all are looking at model, Oregon as a model. So there are several areas that, first of all, I'd say that there are a lot of good things in the regulations where they've laid out a lot of specific requirements for manufacturers, for the service centers, et cetera. But I think there are, what I came away on the roles of the facilitator and this screening process, I think there are confusion, contradictions that would be a problem in their implementation in Oregon and or nationally. So let me talk a little bit about those. So in the facilitator process lays out, you could be a layperson, mean non-licensed healthcare professional, or a licensed healthcare professional to become a facilitator. But in the facilitator model, one of the concerns is that it says things like, you as a facilitator, you can't practice any other, what you do in your facilitation, you can't be using any other healthcare professional that's what's licensed for. So I would say, is that a reasonable burden to put on a licensed facilitator to have to know what every other healthcare professional is licensed to do in the state of Oregon or any other state? To me, that's more of a challenge for how do you ensure, if you're in the state role, that the facilitator's following that. The Oregon does make it clear that these services are not for medical treatment, and they're not for, they don't require a diagnosis. I would just highlight what Alex was saying also, that if you make this all for wellness, then you've pretty much ruled out insurance reimbursement or third-party payment. Because if you don't have a diagnosis and you don't have a licensed healthcare professional, most of the time it's not going to be covered. So in every stakeholder I've talked to nationally, they all want equity and access and want reasonable access. I don't know how you get that if it's all a self-pay model. So, and you have no third-party payment. So I think that's a challenge. And that may be the way the law is or what Washington does, but I do think it's a concern. The other issue that comes up is that in the screening that's laid out, these are questions that the facilitator asks that I would say are very clinical medical. So I'll read just a couple of them. Are you currently being treated by a medical or healthcare provider? Have you had an allergic reaction? Are you currently taking any medications? So it says, would you like to share anything about your mental health history, traumatic experience, causing harm, et cetera? So it's a fairly detailed list of clinical-medical questions. And then the facilitator has to make a recommendation for the safety of using the compound. So the Now, remember, the facilitator can either be a licensed healthcare professional that has the additional training in Oregon, or a non-licensed healthcare professional that's been, taken the training, the minimum training, and so on. It seems to me, in my, opinion, is that's a heavy lift for a non-licensed healthcare professional, particularly in an area where we don't have a lot of research that says who's at risk for taking any of these compounds, for having an adverse reaction, et cetera. So it seems to me it lays a pretty heavy burden on the facilitator who is licensed by the state, but a non-licensed healthcare professional. Another part that I found fairly confusing says that if you are a licensed healthcare professional and you are licensed as a facilitator in Oregon for this, you cannot use any of these expertise or training that you've had as a licensed psychiatrist, psychologist, whatever. First of all, I don't know how you implement and monitor that. It seems kind of amateurish to be at best, to have something like that. I don't know. It seems to me it puts any licensed healthcare professional in a very strange situation where they're meeting with a client. They're saying, well, I may be a board certified psychiatrist or a PhD psychologist, but everything I've been trained and licensed for, I can't use in this session, whether it's screening or facilitation. So I think, to me, some of those things I would hope that the state of Oregon in their final drafts would address or provide some additional clarity, because it seems to me it creates a lot of confusion. A couple of final comments on the disclosure requirements for the consent, that the kind of information that needs to be available to the consumer that's going to use these services is pretty detailed in a number of areas, but it's absent about this issue, what to me would be one of the most important issues. What are the qualifications and experience of the person doing the screening, and what are the qualifications and experience of the person being the facilitator? So if Oregon and you all decide this is where you're going to go, it seems at a minimum, the disclosure requirements to a consumer ought to be to make it clear what the experience level is of the person doing it. And so to me, from a safety point of view, those are pretty foundational issues. One final thing, it seemed to me, was a question about how much is this almost over-regulation, or is it required for safety? That Oregon has relied on these service centers, as I understand them. I'm sure Alex and others know more about it than I do, but it seems to me there's a lot of the regulations about this having to be a separate facility and a specialized facility. Is that really necessary for either safety or efficacy? Because it seems to me it's adding a tremendous additional cost to the whole thing. And so this is an area where I would more bring up, it's more like, is it really necessary for safety and efficacy? Because I think it will add a lot of costs. So those are my kind of initial comments.
Great. I want to go to Bob.
Hi again. First of all, I just want to endorse everything that's been said about safety and screening and cultural preparedness, and somebody who's in trouble probably does not want to be in the psych ER. So I'm going to try to not repeat any of that material. I come at this as a non-physician, a non-therapist, and a phenomenon that I'm seeing in Oregon, but also in areas that have decriminalized, is that when the political process is engaged in order to pass something like Measure 109, a simplified picture is presented to the voting public. Could I screen share for a moment?
Please.
Okay, let me find the right one here. So this is the famous chart from David Nutt and Associates, showing alcohol and heroin as the worst possible drugs, LSD, buprenorphine, and mushrooms as the safest possible drugs. And an issue with this chart is that a lot of people look all the way to the right and make the mistake of truncating the mushroom bar to 0. Oh, it must be as safe as water. How do I undo screen share? Stop share, there we go. So what all of us know, and much of the public doesn't yet know, is what happens when things go wrong, and how often do things go wrong. Here's another screen share. So this slide is almost contentless. Down at the bottom, I've grouped together screening, level of facilitator training, level of intrinsic skill, and the availability of backup or secondary care. And the point here is that to the left, those things in the aggregate go down, to the right, they go up. It is thought that there is some relationship between that and risk and cost. No one knows if those functions are linear. No one knows the slope of the curve. But this is the trade-off that was debated in Oregon. There are people lobbying very strongly for what they call access, meaning low cost. And that's why the facilitator training was put at 120 hours, with the state not allowed to require anything more than a high school diploma in terms of formal training other than the training program for psilocybin. A key point here is that even with a very high level of screening, facilitator training, skill, backup, all the best conditions, the risks do not fall to zero. Brian spoke about cultural preparedness. That would include understanding that basic fact. Sometimes I liken it to driving an automobile or rock climbing. These are activities that everyone knows are intrinsically dangerous. There is some level of danger. Usually they're perfectly safe, except when they're not. And when the culture understands that about psilocybin, in anything more than a microdose, we'll have gotten to a better place.
Thank you, Bob. Want to respond to just a couple things in the chat. Emma's, posted that they have put forward recommendations that would protect licensed healthcare providers. And I think you can all read the chat as readily as I can. I think, and there have been some questions again, are we focusing on the clinical aspect of this? No, we're not focusing on the clinical aspect. This group has decided it does not want to discuss a clinical model. That said, for the wellness model, really, those of you whose careers and day jobs are very much involved with psilocybin, you are sharing your thoughts as is appropriate, and you know the direction that you want the state of Washington to go. You have a sense of what should be, what shouldn't be, and that's great. There are a lot of folks on this call, myself included, who work for the state who will have to implement whatever policy or law is passed. And so to level set, I think it's important for everybody to understand the breadth of both the benefit and the potential harm, even if folks feel the harm is basically negligible at best. But I do think, again, for everyone on this committee who may not be completely steeped in psychedelic therapy or wellness models, it's important to have this information. So I just wanted to give that context as well. I want to go to another question. What if you were writing the law or designing it, what are your thoughts about necessary safety protocols for standards and training? What would your recommendations be? And then we have a couple questions in the chat folks want to ask. So I'm going to go ahead and start backwards. I'm going to start with Bob. What do you think a state should do when they're trying to set something up like this for a wellness model?
I think I'd like mostly to defer to other experts on the call.
Okay, that's fine.
Because I come from a place, there's been a mention in the chat a couple times of decriminalization. I believe that the SAMHSA annual household drug survey says that about 9 million people in the most recently surveyed year took a psychedelic, and that's people age 12 and older. And most of the times that goes just fine. My guess is that the biggest risks are behavioral, like don't drive an automobile, stay away from cliff edges, those kinds of things, which if baked into the culture would reduce a lot of potential harm in the wild.
Thank you. Brian.
Focusing on a wellness model and reflecting some of the comments I'm seeing in the chat about how, the more restrictions are, the more that things become criminalized, that also has its own harms. And so sort of trying to like really balance these things. What's a minimum standard that maybe Washington State can feel comfortable with and people can feel would be sustainable, meaning it's not going to lead to events that are going to make a backlash, right? Is part of the overall sustainability of making this accessible. But just from a pure clinical perspective, a lot of it comes down to who's the client or patient in front of you. And this is where, in Oregon, I've been a proponent of people doing screening who have some type of medical background, or at least being able to quickly escalate to them, right? So there's a lot of interest in Oregon and elsewhere in using psilocybin for treating people at the end of life. I have far more concerns, clinical concerns, when dealing with people with serious medical illness, people with cardiovascular disease, people who have multiple medications on board, people who've never taken a psychedelic before. This is where having preparation that's maybe one session and maybe more than one session, and having a path for that, of making that decision. So it's not just let's meet and then have a dosing session the next day. If you think that someone's going to do basically the Johns Hopkins or NYU model, maybe just one high dose session, right? This is different also from a safety perspective. If you're talking about this is accessible enough that someone will come in, have a low moderate dose, you'll see how they respond. And because there's so much inter-individual variation in response and safety concerns that can come up, that you can work with them gradually over time and then do assessments or taper medications as needed. If I were to have a takeaway from what we see in the clinical data, it is that sort of building people up in dosages over time is probably beneficial to them, certainly for tolerating what a high dose experience can be like, and helping them learn to actively be a participant in the session and navigating that with some experience, but also just seeing how does this person in front of me respond, and do they have some medical history that we should just, as we do in conventional allopathic practice, start them low and slow and then build up towards what might be a more large, transcendent, or possibly more sort of risky situation.
Thank you, Brian. Alex.
I think that it might be worth mentioning just the question of what the wellness model really is, because I'm just curious for the members of this committee if they really feel like it's purely wellness, because it feels like many people who are suffering with mental illness would be coming for this service if it was legalized. So I just want to name that. And with the synthesis data from a couple of years ago, they were turning away about 70% with a very thorough screening process. It's a lot of people to turn away, maintaining the wellness model. And so if it's really the intention of this group to make it very strictly wellness only, there does need to be a training on screening. That's rather extensive. If that's the intention. If the intention is to do wellness, knowing that we're going to have people who are very depressed, very anxious, coming to these services, then we might be building a different model. So I just want to ask that question of the committee: is what are we shooting for? In all honesty, with ourselves, because I think most of the time what I've seen is that people, because I've been doing community mental health for 25 years, people are desperate and people really want help, and they've heard about these, they've seen it on Netflix, they've read books. They're coming for these services, and if they're told it's wellness, they're going to be coming, saying they're well, and saying no to these questions. And so that does take some level of skill to assess where someone's at. And so that speaks to the kind of the training that you're asking about, Charissa, which is, if it's truly a wellness model, they need to be trained well enough to rule people out and say no. If we're just being more pragmatic and we're just recognizing that it's really not just that, then they need more training to understand kind of what level of care, what type of background someone needs to help them. And that's a very different question for safety. Oregon's kind of walking that line in a very interesting way, but especially if you've written into the suggestions, recommendations that people can have a behavioral health background and act in those capacities. Just want to ask the question: are we really shooting for a wellness model, or is that kind of a cover for a legal solve here? Because it's kind of building two different systems.
Fair question. I want to get Henry's feedback, and then we can sort of ask the committee their thoughts. I think, you know, there is a range, Alex, of what's been expressed in this. There is sort of the purely wellness model, very limited touch facilitation. I mean, not in the direct sense of touching, but sort of limited training that's there, but not requiring either a license or an expensive education or any sort of clinical background. So that is sort of the one end to allowing trained mental health therapists to be able to also facilitate experiences and potentially use their training to address higher risk folks who may be more likely of having an adverse experience. There is a desire within this group to have it paid for by insurance. So it's kind of all over the place in a way, but leaning less towards the clinical model of you must have a diagnosis to receive it. But Henry, I want to go to you next, if I could.
Okay, a couple of comments. I pick up on Bob Jesse and some of the chat things that when you look at the risk of other psychotropic drugs, right, for the treatment of mental health, the risk involved in many of those, including antidepressants, antipsychotics, is a lot greater than any of these compounds, right? So in the second paper that Brain Futures did, we highlighted some of this, you know, the black box warnings on SSRIs for kids for violence and suicide. But my concern is that that's not the lens between how people are going to judge moving these highly regulated drugs into, you know, broader use. So what I think in terms of potential ways to address this is having a licensed health professional do the screening and make a referral. Interested in the comments that Alex made about Synthesis experience with that. You turn a lot of people away, and even I'm not sure how many licensed health professionals would want to make that, given that they are referring into, you know, a wellness model. They may or may not, but so that's one way to address at least the screening issue and the potential risk of that people have a side effect or whatever. It's going to happen. My worry is about Oregon, and if Washington State goes this way, is the public reaction, if there are even a few handful of bad reactions and how they're handled. And so in terms of what would happen to the broader push for regulated use of these drugs. To me, as a psychiatrist involved in mental health policy for 4 decades, we have a desperate need for newer treatments and better treatments for common mental health and substance abuse. Desperate need. Most of our medications are old, really old. Our psychosocial therapies are old. They've been around for 40 years. These drugs have the promise of being an effective alternative for people. And so I would really hate for, in the wellness push, there's a backlash against the medical use, right? So I think there are a lot of risks on this. And I guess that I think people would agree with this. It's probably our drug policy in the US is consistently inconsistent at a minimum. So how this stuff is going to be judged is who knows, right? You can't, I've never, you know, so I think safety here is partly like, is there going to be a backlash in how these are handled by different states? So that's one. The other thing to think about is that, because I do think the lack of insurance reimbursement for people with these illnesses that want to get treatment is a big problem in terms of equity of access for these services. So I have a lot of experience in my career with how non-clinical people are used as clinicians in the medical system, both behavioral and medical, and get insurance reimbursement. And that may just be a non-starter in this situation, but there are a lot of examples for people that don't have formal clinical training that are part of a medical team, or they're under a licensed health professional that provide their unique things, and there's no licensure for it other than the state, you know, having a licensure for. So that's one potential it may be just anathema to those who want a wellness model that have that, but there are lots of people doing wellness-related clinical functions by non-licensed clinicians, and they're getting reimbursed for it in that model. So something to think about as you all move forward, but I think this discussion's been a good one. I guess my final issue is, based on the Oregon thing, I think the roles of the facilitators should be much clearer in what the disclosure to consumers. They know what they're getting into. And I'm particularly hearing Alex's thing that a lot of people are going to want to get in for treatment, even though because they have a mental health or substance abuse problem. And it seems to me it's really incumbent for the consumer to know what is the training and background experience of the person that's screening them and going to be facilitating them.
Thank you.
Can I dovetail on Henry's comment?
Please.
Which is, because I really love Peter's comment, which is, let people decide. And, yes, these are incredibly safe treatments, and we're talking about very low, sub 1%, adverse events in terms of like hospitalization to someone else's point. But law of large numbers, we're talking about 20,000 plus people in Oregon estimating next year doing it. So we're talking about, maybe 5 people being hospitalized. And that's not nothing. And to other people's points, that is much less than the current level of hospitalization for mental illness. And so I think relative risk is important to understand. At the same time, it's to Henry's last point, licensing is a consumer protection function. It's to let the consumer know that this person's qualified to treat them. And so if you guys are considering a 1-tier licensure, I do think that would fail in that primary function to protect the consumer, because they won't be able to tell for themselves, especially if they're coming in with a mental illness or addiction, who's qualified to help them and who's not. If there's just 1 tier, right? If we're having people with trauma backgrounds available in the Washington model, how are consumers supposed to figure that out if there's just 1 license to reference? And it also bleeds into insurance reimbursement. I mean, it solves a lot of problems considering multiple tiers of license. It puts more pressure on the state to figure that out, but it solves a lot of issues, because ultimately someone can be educated on the nature and the risks of these treatments, but it's a big ask to ask people to be educated on the qualifications of their providers.
Yeah, thank you, Alex. Yeah, I want to, Emma's put a couple mentions in the chat. One is that we went to a wellness model because it would allow the most equitable access. Again, and we can, in Duncan's review of thoughts, he can share a little bit of the sort of thinking around cost and equity, but including licensed healthcare providers as part of the wellness model who need a higher level of care. And it looks like there have been some separate training recommendations submitted to Senator Solomon, which won't be part of this report since they're sent separately, unless the group has a chance to go over them. Want to ask, Oregon's got 40 hours of experiential training here from Tony. You look for other concurrent-ish licensure. Want to ask just the group, and then I want to open it up to committee members to just have their thoughts or comments on the panel. Are there any groups of people or folks that you would, through screening, be wary and say, this should not be done unless someone is quite skilled in facilitation? Or are there folks who you would say shouldn't have a facilitated experience with psilocybin? And I'm gonna ask
Charissa.
probably, yeah, go ahead, Brian.
I want to address that, but I just want to sort of weave it in with some comments that have just come up, that I think this gets at what I would feel comfortable doing if I were in Washington State or Oregon and doing this myself, right? There's something that I think Oregon has really fallen short on, that I'm seeing with these comments on supervision and the ongoing, care and ongoing contact in the system, that I think is really important. One issue that I have with Oregon, when I was down there and talking with folks recently down in Portland for a meeting that just happened, is, so what happens when people are not doing a good job? from the safety and consumer protection angle of we give someone a license or certificate, but then how do we take it away? What is the state and what is the peer review mechanism for weighing in on someone needs more training or supervision before they can treat more people? And I don't think that's really been worked out there. So to the extent that supervision and follow-up of the providers is important, but also following the clients and seeing how that's going to change. You know, Henry talked about people with mental health concerns getting into the system for treatment. I want to know, what are we doing for them in 3 months or 6 months? Maybe they've stabilized, maybe they're doing a little bit better, but now they're transitioning to more wanting to be in a setting of community practice, ongoing wellness, ongoing personal growth. They're going to have different needs, right? And maybe they don't need as much care anymore. So are we anticipating what I think could be sort of the natural course of people's psychedelic use in a regulated model, that they can be flexible? And this kind of gets at your question, Charissa, is who just should not be receiving this. I think a lot of that actually, you can screen some of that if people are having active psychotic symptoms. I've seen that get worse, and I think we will see that get worse. I know there's debate. I know there's severe limitations on some of the misuse of psychotic diagnoses and how that is, puts a burden on certain communities in this country to say anyone with a psychotic history should not take psychedelics, because that's not always going to be the most clinically accurate description or really predict their outcomes here. But again, if we're following people and they develop challenging experiences, more psychotic symptoms, more paranoia over the course with psychedelics, that could happen. And so when are we going to be able to coordinate around their care and really get them to agree that maybe this isn't the best choice for them? I have seen long-term psychedelic providers develop prolonged psychotic reactions to their psychedelic use. And it's people that you would think, oh, they can tolerate it well. They've shown that they can use psychedelics in the past, and they become unable to function and unable to do their job or care with their families. And so there's a trajectory over time that we have to be watching. It's not just we're going to catch them when they get in the system and then it's okay after that.
Thank you. Alex. Trying to keep track of everybody, but I don't know. Yeah, there you are.
Yeah, I think there's straightforward answers from like the research screening criteria of psychotic disorders or mania or high suicide risk. For me, it's not so linear. It's not such a dividing line, because it's a question of competency for those things. The science answer is we don't know, because we're conservative in who gets into these studies. So there's not been studies per se to put hard numbers down. I think Brian's experience is similar to mine of knowing folks very experienced, no family history, no history of severe mental illness, having serious adverse events, including psychosis or persistent psychedelic experiences that last for the better part of 6 months to a year. And I've seen people with, just in doing harm reduction festival support, as well as running an ER in Humboldt County, I've seen people with severe mental illness use psychedelics and not get tremendously worse, but they're hospitalized frequently enough to kind of get a sense of it. And so I think the science answer is we don't know. It's a question of risk tolerance, but it's really a question of competency. I think if we were to think about 10 years, 20 years in the future, there's going to be providers taking on very high risk cases very carefully and thoughtfully and with that skill. I know psychotherapists who do just therapy-based work for schizophrenia and with high efficacy. And so it's just a question of the skill. It goes back to the expertise of screening, and ultimately it's a question of liability on whose liability. Is it the consumer for picking their own adventure, or is it the provider? And these are kind of the policy questions that you all need to consider: is where are you placing the burden, and how much are you relying on market forces for people to find the right type of provider for themselves?
Henry.
Yeah, I don't think there's clear research literature to show what this subgroup of this diagnostic group or that is high risk. Particularly, you're dealing with multiple compounds here, but even for psilocybin. So, but yeah, there are really two things you'd like to be able to predict, right? Would this be efficacious for this person, whether for wellness or for treatment of a mental health problem, and then is it dangerous, right? So, but we don't, just to be clear, we don't have that kind of knowledge base for all of our current treatments as usual. So, the mental health field and the substance abuse field is pretty much a trial and error field. We have no biomarkers for diagnosis of any of the DSM diagnoses. We have no biomarkers for treatment and that are agreed upon. So, the psychotropic drug business is a trial and error business. You start, if you're depressed, you start on SSRI, and we know that probably the failure rates 3, 4, 5 times before you find the right one. So in this situation, it's not any different from the rest of mental health or substance abuse. But to me, that also places a higher burden on the person doing the screening, because you don't have good research guidelines or clinical consensus about who's at risk and so on. So I think it makes it even clearer that the training and background of the facilitators, be they licensed health professional or not, becomes even greater on terms of this screening prediction about who might have a bad reaction.
Bob, I see you posted a link in the chat. Is there anything that you want to add?
This was an expert panel review of magic mushroom use, as they say, in Holland. It was commissioned by the government. And I put in the summary finding. But going back to the chart that I put up, the fact that they have not ruled it to be a significant public health threat doesn't mean that there aren't casualties. And probably the community of people that would use magic mushrooms in Holland understand that.
Thank you. I want to just 1 second here. I want to look through some of the comments.
Charissa, can I make a comment in response to some of the great
please,
comment
Brian.
about the data coming out of Holland and how when there are communities that have accessed psychedelics, it's not that the sky doesn't fall, right? When it happens in non-medical models. And a reference I have is that in Brazil, the ritual use of ayahuasca has been deemed essentially legal by the federal government back to the 1980s. The federal government formally legalized ayahuasca in religious and ritual settings in 2010. And they came up with some minimum guidelines, like don't give it to children too often. Don't give it to people who are going to drive cars afterwards. Make sure that you do it in a structured setting with supervision that is in these culturally bound sort of ritual use communities. And, we don't see massive hospitalization rates or like the public health system falling apart in Brazil because of psychedelics. We don't see that. But we also see communities of use where for people to have the permission or even the blessing to give another human a high dose of a psychedelic, it comes with years of training. It comes with years of personal experience. There's supervision. This is not something you start to do after a certificate program of 1 or 2 years. A minimum requirement I've heard verbally and formally is 5 years of regular practice with supervision, getting checked in by other people who are there while you're administering these substances in groups, etc. So it's a very involved process, but they have a non-medical system. There is no physician to do your screening or a social worker to do your screening. You do it yourself, but with lots of training and supervision and a group around it keeping an eye on it because everyone's invested in it going well. Now, that doesn't mean that they don't have adverse events. They certainly do. But in that setting, there's a culture that accepts it and celebrates it and values it for part of the tradition of these communities. And there's a lot of, again, supervision baked in. And if you want to access the substance, you have to go through people with more training and more responsibility. So there's accountability in the system that's not just medical. And yet there's lots of accountability if it goes well.
One thing, if I could add to that, I think that is when Washington State is making a decision, it only wants to do wellness. Is that done with a clear vision that this is going to rule out this service for all the people that need treatment for a mental health substance abuse disorder? I mean, so I guess my question is, because it seemed to me the Oregon thing was really trying to do both, even though they leaned on the side of wellness, but it seemed to me there was some element which added probably some of the confusion in their regs about how they brought in a licensed health professional. But I guess, anyway, so it just seems to me that adds another element about was this a policy decision that this is the most important thing to do, not to make this available for people that have serious mental health problems that might benefit?
No, I think the intention of the group is to have both, Henry. I think it's to have the wellness model, but it's also to have licensed professionals be able to act as facilitators for folks who may have a higher risk of an adverse outcome or on whatever you want to frame it as, but not within the clinical setting. So it's kind of it's kind of both is the sense of the panel. We have a few more minutes. I want to go to Tony, who has a question or comment. I'm not sure which.
Thank you. I mean, one thing I think I'm kind of hearing like pretty consistently from everyone is it'd be really valuable to have more public education about psilocybin, how it works, how it helps. And I think that's something everyone here would agree with. Please correct me if I'm wrong. I mean, it seems like there's different groups of people have different ways to provide that information. I mean, one of the issues of, if there was ever to require like a medical consult beforehand is, medical professionals have been trained in like a very hierarchical interventionist model of treatment, which is, kind of exactly the opposite of what the psilocybin experience would be. And so if people are talking to a medical professional first, they could actually get kind of misled about what's going to happen. And so we really need training, for kind of everyone, including, licensed, healthcare and medical professionals. And, maybe there's a way to build this into the bill more than was done in Measure 109, is to have funding for education and different stakeholders. Thank you.
Thank you. I want to see if the panelists have any additional comments. Then I want to give Cody a couple minutes, who's been working with the rest of the committee on putting together a list of papers regarding safety, but want to just go through, actually, John, I'll take your question, then I'll ask final comments from folks.
Thanks, and thanks to the guests today. I've enjoyed the conversation. I'm curious, with no preconceived notion whatsoever, just to be clear, we've been having a bit of an offline conversation about in utero exposure. And I'm wondering, screening and in utero exposure, if any of our guests have thoughts on that.
I don't. I would add one thing about this whole discussion about the medical treatment access versus wellness, is that the training requirements that Oregon has for the licensed health professional, right, is the same as for the non-licensed. So it's what, 160 hours. My question would be for a licensed health professional, does it really require 160 hours for them to be able to prescribe or provide facilitation or screening? I say that because in the other areas of healthcare, for instance, I'll pick opioid treatment programs, methadone clinics, the requirement of even 5 to 8 hours of additional training for license has been a major barrier to having providers do this. And I realize right now there are a lot of interested mental health substance abuse providers that are willing to do all kinds of training, lots of training. I don't know that once this is out and hopefully available to people, the amount of training that you require on top of your existing licensure and certification can be a huge barrier to whether you get people willing to do this. So anyway, it's just another, on the wellness side, it may be different. I don't know. I mean, I don't know if all the people who are not licensed health professionals, 160 hours or 50 hours or 100 hours may or may not be a barrier, but it is something to think about when you're talking about if you hope for widespread implementation and access.
Thanks, Henry. Sunil?
Thank you. I was just wanting to make a comment about Brian's comments about the spiritual communities being a support system. And I just think that that is something that we have talked a little bit about here, about how the state could encourage the development of such communities that have this sort of deep well of experience around psychedelic knowledge and practice, and sort of not trying to reify the divide so much that, one side is the church, one side is the state. I was thinking of examples like, Catholic Community Services provides social services under state and federal granting. And so there's examples of which where the state does partner with organizations that may be spiritual or religious in nature to perform essential services. So that and so the existence of entheogenic churches and psilocybin incorporating or other types of psychedelic churches is something that should be looked at as a public resource, and to try to encourage relationships or linkages rather than just sort of, okay, that's sort of wellness is one thing, medical is one thing, religion is another thing, but that's not really how it works in practice. And remember, the Washington Liquor and Cannabis Board has exemptions for alcohol use built into our law for religious use. And I still think it's it's a big equity issue why only certain groups' sacraments are legally exempt from regulation and other groups' aren't. And I think we should be able to articulate a reason for that if we're going to sort of not say anything about that. But those are just some of the, I think it's a really good point, and I think it's important for us to use all the resources that we have in our population. Thank you.
Thank you, Sunil.
I wanted to get to John's question about in utero exposure, and having gone through the literature a lot, done a few of these reviews myself, I haven't seen really anything, and I think that's what we actually need to be talking about. There is one case report from a study in 1963 where a healthy person working with Tim Leary took psilocybin multiple times during her pregnancy and reported a normal, healthy child after that. That's one case report. And yet, if we want to look broader, there is anthropologic work like that. I think her name is Stacy Fisher, who's an anthropologist in Northern California, who's looked at the use of peyote amongst indigenous communities in Mexico, where taking peyote during pregnancy is seen as like a blessing for the child and something that can be encouraged at times. There are many traditions where drinking ayahuasca during pregnancy is totally forbidden, and then sometimes where it's actually encouraged, and sometimes giving small amounts to children is something that is practiced. So there's ethnographic data from which we cannot generalize to a clinical rule. And I think the biggest thing here is where I've had a concern in, as much as I talk about spiritual communities provide a source of sort of self-regulation and a lot of wisdom, I've also had a concern where in spiritual communities, someone will say, no, I've seen it before, it's safe. And so that level of informed consent, how do we educate non-clinical providers to do really good informed consent when there are potential clinical risks? That's what I'm talking about, safety. And how do we really educate people who come at this with a religious conviction that this is good for you as it was good for me, and yet also allow them the space and time to understand objective discussions around, we just don't know that in a robust way. That's like the real safety issues that I'm going to see coming up in any of these sort of mixed professional, non-professional models, or frankly, even amongst the professionals who start to get religious convictions that this is going to be good for you, my patient. I can't wait for you to try psilocybin. The consent part is really important.
Thanks, Brian. Want to just see if Alex, Henry, or Bob have any sort of final comments. I do see that Senator Solomon has joined us, and I want to make sure Cody has a couple minutes to go through his list of resources he's been working on. So Bob, any any last comments for the group?
First of all, a correction. I did some typing after I put out the number 9 million. Turns out the correct number for 2020 is 7.1 million. Still not a small and not a huge number of people taking psychedelics. But by and large, the sky is not falling. The question will be what happens when use becomes more widespread and moves into communities that aren't operating out of a natural desire to take psychedelics. Somebody telling them this will be good for you. So I don't think we can necessarily generalize today's safety picture, but I also don't think the sky is going to fall. So everything that you will do is going to be helpful, and there will still be casualties, and the sky won't fall.
Thank you. Henry.
Well, I think these Bob, Jesse, Bob, and others, it's really good to have the actual facts and data of risk, but I don't think that's what you're going to be judged on. I mean, I think you're going to be judged on, you know, the history of these drugs and people nervous about them. And just to, you know, point to the inconsistency of our drug policy, right? Alcohol is still our most dangerous and destructive drug, and anybody can get it if you're over 18 or 21. And so it's wide open access, and nobody required to go to, you know, a guide to use it, et cetera. So, but I don't think that, I really think the lens is going to be the history of LSD and all the misuses of it in the past. And I really worry about the wellness only model excluding all the people that have these diseases. I think it was good to hear, Charissa, you all want to do both. I think the way those Oregon regulations are currently written, I don't think they're a good model for the medical side. In fact, they pretty much make sure that, you know, it's even ethically, I think, conflictive for a licensed healthcare professional to say, well, I'm meeting with you, but I'm disavowing all of the training and expertise I've ever had. But that's the way they're written today. So I almost think you probably need two tracks if you're going to go for the medical side and then have the wellness side. So, but anyway, good discussion. I think, you know, Oregon's up first, so they're going to make all the mistakes, right, that you can learn from. It's always, I think, better to be the second in line than the first in line.
And Alex.
Yeah, I would support what Bob said. The sky's not going to fall. In fact, I would estimate that suffering would overall reduce with large spread access, because these are remarkably safe, safer than what's out there now, safer than the status quo of the mental health crisis that we're in this country, including Washington. You know, I think it's important to think about the casualties and what we can do about it. You know, a lot of the medical model is could be maligned in all sorts of ways, but I consider myself an advocate for people who are very vulnerable. And so I think, yeah, politically, 5 people in the ER a year, that could be dangerous for the politics of this. I actually care about those 5 people. And so something I would invite this committee to consider is a safety net program. You know, that would be by default exist when the medical model kind of comes on board. But without that, you know, because I worked at the Zendo, I worked at Whitebird, I worked at RockMed, you know, these communities where large amounts of psychedelics are kind of basically freely available in these festival settings are busy services with trainings, and they're open 24 hours a day, and they're busy and they're full. And so, and I'll say that, you know, in my ER in Humboldt, the rate of people coming in psychedelic crisis went from once every 6 months to once a month after How to Change Your Mind came out. So I would just invite people to consider what kind of service could be encouraged or funded that could be on standby, especially in urban settings where there's going to be a higher population of use, to support those rare cases, right? So it's not, so we can give people the freedom, right? There's been a lot of comments about this doesn't outweigh people's freedom of choice, and I agree with that. But then it's just what's kind of safety net can we build for people, and not necessarily rely on community to step up per se. These services cost money to staff them 24 hours a day. It costs money. We've thrown around ideas about having every service center in Oregon chip in towards something like that. You have to consider other policy considerations about moving someone against their will, and in that kind of state would require something akin to a psychedelic advance directive, or changing the psychiatric hold laws, because if you put someone on a hold, you have to take them to a psychiatric center. So there's complexities when you think about a safety net, but I would just really encourage this group to really think about that as an additional safety measure. It's absent without the medical model. And it's important for those few cases that really need it. And it's not just, in addition to that, it's not just the skill set of calming someone down. Like there's been a lot of research on spiritual emergence. There's a lot of very qualified practitioners who've been carrying that lineage for quite some time. Some of those cases are really important for those individuals to have support through that experience, not just to have it shut down. And so there's all sorts of ways to really consider, yes, this is going to be better for the community if it's fully out there and with low barriers to access. But for the people that will be harmed by that, what can we do for them to build a system of support around that?
Thank you. Cody, want to give you a couple minutes and then we'll switch to Senator Solomon, see if he has any comments for the group.
You're talking about me, right? I know there's two Codys.
Yes.
Okay.
Yes, Cody. Yes. Cody Z.
All right, Cody Z. Yeah, two Codys with K. So in any case, over the past couple of months, we've been drafting this document, which I will post a link to in the chat. Anyone should be able to access that and also comment. We're also always willing to hear more information and get more opinions on this. Also, I don't want to say this is just a completely exhaustive list about what the concerns of psilocybin services are. It's not. This is based off of, at least some of the topics I put in here were based off of what I hear from politicians, what I hear from policymakers when talking to them about psilocybin. This is addressing the most common concerns, and also some individuals who are in the psychedelic world and have some more clinical background and more information on pharmacology than I do. So I just once again, this is not just like a completely exhaustive list. This is just what are some of the most common concerns. So the one I hear the most when talking to policymakers and talking to the general public is, of course, what about difficult trips? Colloquially, I think they're more often known as bad trips. And we wanted to make a very conscious decision in the language here to use difficult trips as well. Namely because some individuals, even over the course of experiencing a anxiety-producing psilocybin experience, can still find that beneficial following integration therapy. So we wanted to be conscious of that and also be aware of some of the resources and support structures that do exist right now in the psychedelic world for individuals who do experience some of these difficult trips. So our bottom line on that is difficult trips remain an important concern, but one that can be mitigated with proper training and integration. Of course, another big one is psychosis and psilocybin consumption, which I think we've heard from several of the guests here today regarding as well. So it seems like there might be some possibility for some groups and some individuals to experience psychosis induced from psilocybin. It's not clear whether or not it's people who are already genetically predisposed. And I will say, some of the data is still mixed on that. And our bottom line is clients with a history of mental illness should be encouraged to get the advice of a mental health professional prior to engaging in a psilocybin service session. I know we've also added that the mandatory disclosure of mental health history would be an egregious violation of privacy and lead to degradation of clinical providers. So we just want to recognize that and acknowledge that as well. The third point is how long should clients wait to drive home following consumption of psilocybin? That's another one I hear from many different lawmakers and other people. Clients who consume a full dose of psilocybin should wait 4 to 6 hours before driving. We've also had some extensive discussion of microdosing here as well, and the potential of microdosing being added to the RCW. I don't think that should be necessarily the same weight of time, and I don't think anyone else here thinks that either, mainly because it is a sub-psychoactive, sub-threshold dose of the substance. So it seems kind of silly to make individuals wait for 6 hours when taking
Cody, I'm sorry to interrupt. Can I ask a question? You've got these, do you have these points in the document that you have posted? Perfect. I apologize for cutting you short. I recognize that we are about at time. I want to thank our guests, Alex, Brian, Bob, for joining us, and really appreciate your thoughts and insight. You're more than welcome to stay on as participants listening. And Henry, I apologize. Yeah, you're more than welcome to stay and listen to the rest of the meeting. I want to ask if Senator Solomon has any comments for the groups. He's been able to attend most of these meetings. I'm not sure when you were able to join this morning, Senator, but wanted to see if you have any comments for the group.
Yeah, absolutely. Thank you for being here. Sorry I was late. I had to do some things, but I joined about 8:45, so I got a good part of this. It's very clear to me that we have a valuable collection of experts here, a brain trust, right? And that's a pretty big deal. You bring a lot of research intensity, a lot of personal experience. Obviously, there's been a practice going on for some time that maybe legislators weren't quite aware of, but I think there's been a lot of responsible work done within those practices that will inform legalized practice. So I'm very excited about that. There's hundreds of issues that the legislature deals with, and it's not always easy to bring a task force together, people that are committed, and it speaks to not only the level of interest that you all have, but sort of the unbelievable level of interest that our entire society has. As soon as I dropped this bill, I was inundated with media reports, serious media inquiries, not like, oh, are you, Timothy Leary, but like, we're really excited about the future of this for our mental health challenges. I mean, that goes from the Seattle Times all the way through Politico.com, which is now I think rivals the New York Times in readership, might be bigger. And then, the New York Times has been reporting on this. It's been an amazing level of interest. I appreciate, I think Oregon did a good job, and having you all here looking through the nitty-gritty details of that legislation and this bill that we've introduced makes sure that we don't miss any opportunities to improve what Oregon is doing, or to move, or could also prevent us from moving ahead with something dangerous. I think there's a big question about certification for providers. Should it be a 40-hour training, or should it be more? I think there's room for argument that Oregon is too lax on the service provider side certification. So these are things that I'm going to lean on you to help me work through. As I said, there's a tremendous amount of political attention to this bill, but I would say that with any bill, especially a new idea, getting enough legislators to just focus on it, especially in the healthcare committee, and prioritize it when there's going to be lots of questions, lots of other bills flying around. We're going to be dealing with abortion care bills and hospital merger bills. So just getting individual legislators to focus enough on a complex bill like this is probably the main challenge. I think the question of safety is a challenge, but I think it's perhaps a sub issue. I don't want to overstate that. It's an issue, but just getting enough focus is you're competing for attention, right? That's the number one challenge, I think, in the legislature. And I'm reaching out to my members, but again, it's hard for me even to get attention from the chair sometimes on this issue. But as we go in person, I think that'll be easier in person legislating. In terms of the challenge, question of a wellness model versus a non-wellness, I guess, relying on diagnosis for service model. the main concern that I heard from like the Washington State Medical Association is you can't require provider licenses to be jeopardized by having them or requiring them to participate in this. And so I don't know the details here. I suppose if medical providers voluntarily provide their services, that's one thing. We don't really know how many will. But that's why we sort of went down the path of the wellness model with, screening and an optional consultation as opposed to requiring diagnosis. And I also think that, not sure how this is going to cut, but there's an argument to be made that if you don't do the wellness model and it's just a diagnosis model, how's that any different than just waiting for the FDA to give approval? And why don't we just wait? Why do we need to pass a bill and spend time on it when the FDA is going to approve it? And I think we know that the FDA might approve it for very certain specific diagnoses once every 5 years or so, and it'll be a slow plodding process. And what we want to do is move that along in a safe way. So I think that's the reason for the wellness model, or one of the reasons. I also think that people who aren't diagnosed with a mental health disorder can benefit greatly from that for a variety of reasons. And I don't want to exclude them. I think, our relationship with nature in Western societies is a mental illness. It's lacking, and we are breaking our natural environment to the extent that this can sort of reconnect us or make us more aware. I think that's a huge issue, and that falls, I think, under wellness, because we wouldn't diagnose maltreatment of nature as a mental health condition, right? So it's just so many outside the box ways to think about this, just based on the thousands of years of historical use and different cultural perspectives. It's endlessly fascinating. So, and I guess lastly, I think this whole good trip versus bad trip thing is, I think it's sort of silly to think about it in such binary terms, right? I mean, there are certain trips that have anxiety in them, but the better facilitators we have, the more we can turn that into personal growth opportunities, right? So I think if we can stop talking about it in a good trip versus bad trip way, and understand that it's just a continuum, like any other movement through trauma, any therapy practice that moves people through trauma, I think that would be a benefit. Anyways, so thank you very much. And I will continue to lean on your expertise as we go through this process. And I'm hopeful. I don't know how the legislature is going to treat this bill, but the more we raise the profile, I think we'll open minds. So thank you.
Thank you, Senator. I want to turn now to Duncan, who spent a good amount of time talking with all of you. Duncan, please share what you feel is appropriate today. I know we cut you a little bit short. If we need to have you, follow up a little bit at our next meeting, that's fine too, but it's all yours.
Yeah, thanks, Teresa. I obviously talked to many of you. Beth, if you want to go to the next slide. I talked to 14 of you, and I really am kind of going to regurgitate. I managed to kind of consolidate all the ideas that you guys gave to me, and I consolidated them into categories. We talked about safety and equity in our interviews. I think today, because of limited time and because of the theme of this interview, we can just stick to equity probably, and stick to safety and finish equity another day. But I'm going to just outline kind of what was said on each topic, and then I'm just hoping for your feedback. So after every slide, like if people want to give their feedback, we can't spend too much time on each, but I'd like to give you guys the opportunity to react to and respond to what people said. Next, Beth. Thanks. And so kind of here are the categories that I divided everything up into. One thing I'll say before we go into it is a lot of these ideas are definitely far-ranging and they don't completely flow together. And there also will definitely be some questions surrounding practicality and implementation with these ideas. But I think what's important is that we get these ideas out there and we talk about them and they get to a higher level so that we are at least aware of the options that we have. Because I think there are a lot of good ideas, even if some of them maybe would be complex to implement. So let's start with the first slide, Beth, if you want to go next. Okay, so first section is just basic facilitator training. And so we have 4 main ideas here. First, a lot of these things we talked about today, people have recommended that we need a greater experiential component to facilitator training. And so that can work in the form of working with a trained facilitator in active care, or during the training, kind of having an experiential model. An individual suggested kind of a guild model. So facilitators should be as involved as possible and represented in kind of deciding the process for what the state set as criteria for training. And so whatever administrative board is formed, facilitators should be able to give feedback onto what facilitators are being trained to do. We have an apprenticeship model here, which we've already touched on. And so the concept of this is that we are requiring 1,000 hours over 1 or 2 years of supervised training. And what this training would allow people to do is work and be paid, but they do not achieve their full licensure until 1,000 hours are covered. And they can fill this apprenticeship through group work. And what you're doing is you're working alongside a fully trained individual to get that experiential training. And as a side note, there should be a panel that is able to review underground or shamanic practitioners that would be able to prevent bottlenecking, because there is this concern that we wouldn't have enough practitioners to be able to be worked with so that facilitators could train under this apprenticeship model. And then lastly, on this slide, there was a suggestion that we should have an outside entity in the psychedelic space that could possibly pair with the state eventually for the training and regulation process. So we do have this large body of individuals who have expertise, and ideally that would be integrated into the state implementation program. Does anybody have thoughts on that before we move on to the next? Anything to add, contradict? I can't see everybody.
Not seeing any hands, Duncan.
Great, we can go to the next slide then. All right, so next, we've discussed this today as well. There's kind of the discussion of the uniform or tiered system. So many people agreed on the fact that we should not require an advanced degree to become a facilitator. So the high school diploma seems as though that should cut it as the only educational qualification. And there was definitely kind of a debate surrounding this concept of additional trainings and whether those trainings will be opt-in or not. And so while for the most part, there was consensus that there should be a baseline instruction, and that could look like 120 hours. There were individuals that were suggesting different things surrounding whether certain diagnoses should be treated with additional training or not. And so I think the questions that were brought up were whether individuals with certain diagnoses should be mandated to work with people with higher levels of training, or whether that training can be opt-in. There was a suggestion that certain facilitative centers could emerge that are experienced with working certain populations. So you're marketing to certain diagnoses, and so you're more fit to train these individuals. But I think there's definitely a debate surrounding how do we train, how do we create these additional trainings, and then whether individuals are mandated to participate in them if they have these diagnoses. And then lastly, a couple individuals did suggest kind of a dual medical wellness system in comparison to simply the wellness system, arguing that it's needed to deal with individuals with higher rates of negative outcomes. So we do need to rely on a medical system, was an argument that I heard in the interviews. Any thoughts on that, or should I continue? Great, we can go to the next slide. So screening, there are a lot of kind of complications with this and a lot of discussions. One thing that was noted is that we need to expand our training for screening. So at least 3 hours of the curricula need to be focused on screening and how we are kind of working with individuals to understand their fit for the training. Someone argued that within a dual medical wellness model that we need a therapist required for integration. So that kind of moves into the next discussion, which is on the integration of mental health professionals. But once again, we're seeing individuals that are arguing that a medical system could serve as extra support when facilitators feel as though they could not provide effective care for an individual, possibly with a serious mental health diagnosis. Screening must exist on a case-by-case basis. So realistically, while we can use diagnoses as a model, this individual is suggesting that we really need to train people to be able to kind of adapt to each individual and make a decision not based purely on diagnosis, which potentially had the potential to be exclusionary, but really to work with the individual and see what is best fit for them. We also had suggestions that we could, and we talked about this today, possibly a variation of dosing. And so depending on the risk profile, you start with a lower dose and maybe move up. And then also, as we talked about today, screening is not just for mental health diagnoses, but also drug contraindications. So we have to have a full look at screening. Next, Beth. Thanks. So I thought this section was particularly interesting. I had a lot of unique recommendations here. So firstly, as we just talked about, licensed behavioral health professionals must be allowed to become facilitators, but safeguards have to exist so that they can practice without fear of losing their license. In my interviews, I think it was acknowledged that this is going to be more complicated than we might see it as. It's not as simple as just including something in the bill to acknowledge that facilitators cannot be punished for partaking in psilocybin implementation, but it could take the form as an executive order. We saw that in Colorado as a possible model, but many people did emphasize that we need to have some sort of safeguard to protect licensed health professionals. There was a discussion of possibly a model where there was a licensed mental health professional in each facilitative center that could serve as not only assistant for screening, but also kind of as extra aid in cases where there is bad outcomes, just kind of as support and this integration of the medical world into a wellness model so that we do have this ability to use higher levels of mental health training in instances where there are bad outcomes. There was also the argument made by many people that the medical model for those maybe less acquainted or educated in the psilocybin world, that they could use this as a method to combat stigma. So the medical model in some way would legitimize psychedelic facilitation. And then lastly, an individual noted that while the concerns about safety and training are valid, what we are discussing is psilocybin facilitation and not therapy. And so then in some ways, as long as individuals are properly trained in facilitation, there may not be a need for higher levels of training. Thanks. We can go to the next slide. Extended integration. So this is something we actually only briefly touched upon today, but I think is a really important point. So extended integration is the term I've been using just for any sort of care or treatment post-integration session. And so what does it look like for individuals who have received their trip and have done their integration session and then need more care in whatever form that takes? And so most people agreed that facilitation centers should in some way provide assistance, but whether that's through referrals, in-house services is kind of the question. Integration is realistically going to have to be optional, is what most people said, but should be strongly encouraged. And a couple individuals suggested that facilitator centers need infrastructure built in. So there needs to be a model where individuals can kind of be streamlined straight to mental health services in any form. And this could take the form of group work. So there could be sessions run by the group, by the facilitative center, where individuals could come in within a community and participate in some sort of kind of extended integration and continue to work through their experience. And then other individuals noted that extended integration is really a different type of work than facilitation. And so it should not necessarily be done by facilitators unless there's more training. So theoretically, that could be done by a therapist, somebody who's more experienced and really just working with people in a therapy setting. And then lastly, an individual noted that participants should be able to maintain some sort of relationship with their facilitator post-integration session. So I don't know what that would look like. I think there is an acknowledgement that there could be some sort of extended integration built in with the facilitator. We can go to the next step. Oh, so that's actually the end of safety. And so it looks like we do have time to move into equity, but I'll stop here. If anybody has any comments, that was really kind of the broad overview of what I picked up on from the interviews. And you guys should all also have a document that goes through these in more detail. Yeah, Jermaine, do you want to share?
Comment I would make is having worked with a lot of different behavioral health specialty groups over the years to expand their services. The more specialized you make the service package, whether it's for wellness or treatment, the harder you will have for dissemination to make it available to everybody. If you have a very specialized service package that can't fit in with the rest of the medical provider system, and I'm talking about the big medical systems, the harder it's going to be to have enough of services available for all the people that might benefit. So I just think it's important to keep that in mind. I've worked with some of the suicide groups and other specialty groups, and a lot of times they really want to make whatever they're doing so subspecialized. It's almost like creating an additional delivery system. While that may be ideal in some ways, you have to realize is that may then slow down adoption because it isn't something that the rest of the healthcare provider system would adopt. So just one comment.
Yeah, absolutely. I think that's a good point. Jermaine?
Yeah, thank you. One of the things that I've noticed, particularly since we talked, Duncan, is that an issue that isn't being addressed is what would be the frequency with which someone could have the health-based experience. Or like some people today were talking about a start low, go slow model, which if you use it with a typical pharmaceutical, you usually do a half dose for a week or so, then you double it. I know microdosing is like maybe 3 times a week because otherwise there's tolerance, or every other day. But with full dose, can someone come back in a week? If this is like a wellness model where people can choose themselves, could someone choose to come have a full dose every day? I feel like this is something that when a bill comes to the floor is going to perhaps be asked by other legislators. And I feel like I haven't heard anything about, and I don't think that the research that's been done has really looked at this issue of safety and frequency.
Mm-hmm. Yeah, thanks for that.
So if anyone could comment, yeah.
Yeah, Brian, Alex, Henry, anybody on our panel today have thoughts?
On the frequency question, I'll just refer to sort of observationally, a lot of communities of use in the spiritual religious domain practice often no more frequently than every 2 weeks, and often it's more every month or even more spaced out, depending on the sort of the purpose of the work and how high dose is. That's quite variable, but there have been some clinical trials that do this kind of lower moderate dose and then a high dose as soon as a week later. So that's been done in recent clinical work. You could try that. But honestly, if someone's doing this for medical purposes more than once a month or more than once every 2 months in an ongoing way, I'd have questions and concerns about why so frequently and so much high dose work, when especially in populations we don't have a lot of experience for how to really work with like severe, PTSD or treatment resistant depression, et cetera. And you guys would be at the cutting edge of that.
Yeah, I don't really have any specific knowledge on the dosing levels or frequency, but I would point out again in the Oregon draft rules, the facilitator, whether they're a licensed healthcare professional or a non-licensed healthcare professional, is not supposed to make any decisions about dosing. And it's another vacuum or a missing point in their regulations. It says the service center can make these dosing decisions, but it doesn't say who or what expertise is needed. So I would think the more you move into dosing frequency or level, you move into what are traditionally a medical decision or a clinical decision. So it brings back into the question about who can do that, who should do it, and are you creating additional risk, or either theoretical risk or real risk? So.
Yeah, thank you, everyone. I think we have time to move into equity now, unless there are any more thoughts. I'll continue. Oh, Emma, you want to add something?
Yeah, I just wanted to highlight Tony's comment in the chat and expand on it a little bit. In the apprenticeship model, a lot of the questions around safety and competence of practitioners would be taken care of by the supervision hours. If people are working with an experienced facilitator lined up with somebody who's offering similar scope of practice to the type of communities that the practitioner wants to work with, they're going to get a lot of experience and be directly trained by somebody who knows specifically how to, boundary dosage, how to boundary frequency of use, and deal with all the different safety concerns. And so I just want to really highlight that as something for this panel to think about, of that, experience under someone who's really facilitated helps with a lot of these issues, and that the apprenticeship model is something that's used really extensively in both the shamanic spiritual traditions and also in the more Western oriented therapy traditions as well.
Great, thanks, Emma. Okay, so I'm going to move on into equity real quick. If we've covered the safety comments, I think this equity section is really valuable, and I appreciate all the feedback everybody gave, because I think when put all together, it kind of has turned into a pretty comprehensive list of possible ways to concretely approach equity. But we're going to start just with some areas to be wary of. An individual acknowledged tokenism, so the facade of equity without action. As we've talked about multiple times in this work group meeting, psilocybin is not a money-making scheme. It is in many ways our opportunity to engage in something that is sacred to people and communities, and we must respect that. I think that's really important to acknowledge. There is definitely concern of venture capital from outside interests, and to a certain extent, obviously it would be ideal if we could maintain local interests and community engagement. There was a recommendation to avoid the Washington Student Achievement Council, and the argument for that is that the deposit, the legal consultation, other fees involved with that would increase the time and the ability for new facilitator training programs to get off the ground. And so ideally, and the individual that shared this could elaborate, but ideally we would have some other way of regulating and auditing new facilitator training programs so that the cost could be less and they could get off the ground quicker. And then lastly, there's the acknowledgement that the licensing, production, and distribution of cannabis in Washington was a model for what not to do in terms of equity. So I think in many ways we do have to rethink how we are approaching equity and kind of in some ways learn from our mistakes. Does anybody have anything to add on those points before I move on? Okay, so let's go to the next slide. So this question was about affordability. We basically just asked, what do you see as affordable? Because I think that's kind of the first logical step to go to when we talk about equity. And so we had a variety of suggestions that all kind of came from different perspectives. And so, I mean, just to walk through them, we have a range from 60 to 500. And I acknowledge in the interviews that this is a difficult question, but I think this slide itself kind of lends an interesting perspective to kind of how we're approaching equity and what are the concerns. And so people suggested kind of a sliding scale or a cost sharing model. Ideally, insurance coverage would be involved, but in a wellness model, I think that adds complications of what can be covered by insurance. and in what form. Many people suggested group sessions as a possible way to provide equity, so that lowers the costs considerably theoretically. And then we also had discussions of scholarship and voucher programs. So acknowledging within the bill possibly that scholarships and voucher programs can be accepted by facilitative centers would allow for individuals in need to access this for a reduced price. And then lastly, it's important to acknowledge from an insurance perspective that theoretically, if it's to the hospital for a mental health emergency, can cost around $10,000. So in many ways, if this program can get off the ground running, we can, from an insurance perspective, even be saving money. And it really does, in the long run, save for all individuals involved. And yeah, we can go to the next slide to elaborate on all this. So once again, group sessions were mentioned many, many times throughout the interviews. And that's both for facilitation and extended integration, as I talked about in the safety side of things. It's an effective way to kind of build community as well as to increase the amount of people that can be using these services while lowering the cost. Bill wording should encourage accommodating scholarships. So any possible scholarships or voucher programs that exist, facilitators should be encouraged to accept those to allow individuals to participate. There was a suggestion that the lottery system for licenses, if a lottery system exists, should be integrated with the social opportunity program. And I'll get to that in a second. But the social opportunity program would have some sort of criteria in which there are possibly 20% of individuals who are applying, or 20% of facilitative centers that are applying would have to qualify for the social opportunity program to ensure that programs without the means can get their foot in the door easier. And then we saw a suggestion for telemedicine as a possible use for cost reduction, and that would be for integration and screening purposes. And then lastly, there was a suggestion that facilitative centers should be required to write an equity plan. So in their application process, they're kind of outlining the steps that they will take to approach equity in whatever form that is, and that plan would be evaluated by the subcommittee that is involved with equity for facilitation of psilocybin. We can go to the next slide. And so here's our social opportunity program specifically recommendations. And so just to remind everybody, this was in 5660. The social opportunity program identifies distressed groups and individuals that apply with certain criteria, and then attempts to give aid through both financial assistance and logistical assistance. And here are just some small details about what could be added to the social opportunity program to make it more inclusive and more effective, including possibly a civil legal aid program to help with compliance to the regulations that will be set for facilitative centers, and then the voucher program, et cetera, et cetera. And then we can go to the last slide now, because we are running out of time. And so these are just, you all should have been sent the kind of full memo, but this is just a selection of kind of other recommendations that were included in the interviews. Acknowledgement of all the research that should be done / should be explored more surrounding certain contraindications, religious carve-outs and protections for manufacturing and use. We talked about that today. Research programs to be built into facilitation so we can continue to gather much needed data on these issues. A discussion of kind of proper dosages and strains of mushrooms and how that will work. So thank you all for participating in my interviews. I realized I kind of ran through that quickly, but I thought it would be important just to get through today. But thanks again for all your input. And we have some time for any comments now, I think, Charissa, unless there's anything you want to add.
Yeah, we have about 3 minutes. I think, thank you, Duncan, for your work and everybody's time sharing your thoughts with Duncan. I think we do have another meeting planned on the 2nd. I think we want to have some continued discussion about equity and perhaps social opportunity programs, along with hearing from our colleagues at the Department of Health. So I want to be mindful of everyone's time. I want to thank our guests again, Alex, Brian, Henry, Bob, and I do see Senator Solomon with his hand up.
Thank you. This is a general comment, not to anything specific, but I think I'd say let's not think of this bill as the only possible bill or the end all be all. I think we are taking a pretty revolutionary concept that hasn't been passed in any state legislatively and trying to pass it. So I think we need to be mindful of how many concepts we introduce in addition to what's already in there. We can think of it strategically as maybe this is bill number 1, then maybe in the future, something around insurance, et cetera, et cetera. I think we need to also just think about it that way, or I need to think about it that way. Because the more you draw fire to a bill, like if you add a number of different things and get other constituent groups against the bill, it makes it very unlikely to pass. For example, insurance, like, are we going to require an insurer to insure something that is illegal federally? Like, I'd love to do it, but I don't see a path for that right now. So that's all. Thank you.
Great. Well, thank you. I want to thank everybody for your time. Really good discussion and participation. Again, thank you for our guests. We will meet again on December 2nd with a further discussion on equity social opportunity program, and then hearing about it from the regulatory frame as what is possible now and what might need to happen in order to move this work forward. So again, thank you, everyone. Happy Halloween Day, if that is of interest to you. And if not, everybody have a good rest of the morning and day. Thanks again. Take care, everyone.